is always hard after lunch. I know you saw some clips of Games of Thrones. I promise we're not doing that. We were testing for audio, so but that might have got your attention for the afternoon. Thank you. This really is a special time. I was really intrigued and moved by the topic that the planners for this conference selected for this year's event, the success of failure. And I think it is very, very common that failure is kind of something we ignore, we don't like to admit, sometimes we don't think about. That's a natural human tendency. But I am here to say that some of the most beautiful gifts in life actually come from moments of failure, moments where you have the courage to embrace it, and you have the courage to actually learn from it, recognize it, and do something about it. And I'm going to share with you a couple very personal stories that we have had at Children's Hospital Colorado that have been transformational in how we think about safety. And before I do that, there's two narratives to tell. I had a wonderful introduction, thank you. I work in an extraordinary organization. So I want to tell you about that, the bright side, the good side. This is actually a picture our Chief Quality and Safety Officer took when he was in Switzerland. It's a beautiful castle sitting on a lake with the beautiful Swiss Alps in the background. And this is one tale. This is the beautiful tale of Children's Hospital of Colorado. And you'll see the same picture from a different angle when I tell you some of the failures that we've had and how they have inspired us to be better. We have been for 20 years one of the top 10 children's hospitals in the country. We now are the 5th best children's hospital in the country. We are one of the largest. We have increasingly had success in how we've been able to recruit world-class talent from all over the country and increasingly across the world, where some of the best physicians and scientists are choosing to come live in Colorado, be part of the CU School of Medicine, and practice pediatric care at Children's Hospital. Our mission is over 100 years old. We started as a tent in City Park in downtown Denver by some very inspired women who saw that in the early 1900s, children were having trouble breathing, too much dust in the streets, the sewer systems weren't working, and so they created a safe space in City Park where there was grass and there was fresh air, and they built tents. And moms and dads would bring their children, and that's how we started. And over 100 years later, we have 4 key cornerstones to what we do as an organization. We've always been about patient care, how we care for children. Research. In about 1950s, we started really making significant investments in not just caring for children, but how are we going to solve and find cures for what was going to be today's disease, but a cure for tomorrow's care. Education. We have one of the largest training programs for pediatric physicians, nurses, pharmacists, and other healthcare providers in education slots, both in the undergraduate level and the postgraduate level, helping train a very scarce profession of pediatric specialists. And advocacy. We spend over $174 million giving back to our community in how we develop advocacy programs, support programs for children across our communities, as well as legislative advocacy at both the federal and the local levels. We recently went through a strategic planning process, and from the bottom up, from the heart and soul of the organization and the over 10,000 family members of Children's Hospital that are employees, our medical staff, and our volunteers, created a new vision. How are we going to be about the health of the child? Got rid of the word health care, because as health care is in a transformational period, we can't just be about the place where people come for a health care episode. We need to start thinking about the holistic, comprehensive essence of health and what that means for children in our communities and our communities defined broadly. We need to have the innovation to reimagine the future of healthcare. And then we need the courage to realize it, not just dream about it, but to do something about it and make it a reality. And our values, we are a caring community called to honor the sacred trust of our patients, families, each other, through our values of humble expertise, generous service, and boundless creativity. And again, all of that inspired from the 10,000 employees who touch our organization every day to create the values and the vision for the organization. We are seeing children from all 50 states and over 20 different countries now. We really are the primary children's hospital for the states here in the Rocky Mountain area, and increasingly we're becoming a national, international destination for care. We have 17 locations, main campus, and then 16 other locations where we are providing service close to home for families across Colorado. And here in southern Colorado, we have 4 locations and are so excited about our investment to build a dedicated children's hospital in this community that should open in 2018. We've heard a little bit about our statistics. We are the only level 1 pediatric trauma center in about a 1,000-mile radius. And so we serve children flying in for trauma, some of the most severe cases of trauma into our institution. We have about 19,000 inpatient admissions, it's over 110,000 days of care. We are taking care of over now close to 1 million visits for children across those 16 locations. And another important thing is our outreach. We will take our physicians and our nurse practitioners who are subspecialty trained and send them into rural parts of Colorado, Wyoming, New Mexico, Montana, so that they can bring care locally into those communities that have hard-to-serve areas. We're also increasing telehealth. So we'll do over 1,200 outreach clinics in over 24 communities where there really is hard access to medical care. We continue to be recognized nationally as not just one of the best children's hospitals. Our magnet designation, there's only 3% of all hospitals in the country that have this magnet designation for nursing excellence, and we are one of those and have received that 3 times in a row since its inception. And the award that is most applicable to the topic that I'm wanting to share with you today is the American Hospital Association Quest for Quality Award. So last year, we were the recipient of this award over 6,000 hospitals in the United States of America. They selected Children's Colorado as the hospital over all others that was advancing quality and safety more effectively and more creatively than any other hospital. So that's the bright part. Now, and I'll tell you, well, I'll pause on this before I get to the dark. They found 4 key areas why we were selected above others. How we innovate around reducing preventable harm. So target 0 means we are shooting to have 0 preventable harm in our organization. And I'll explain preventable harm in a minute. What best practices do we employ? What's our culture? How visible and transparent is preventable harm in our conversation across our organization? How fun is it? How do we involve patients, families, everybody, from the board of directors to every employee in the organization? What does that look like in our community? How are we using technology to actually help accelerate this change? And then how do we really, again, incorporate the patient experience into that change? So those were sort of the 4 domains where they measured all hospitals, and we came out on top. The other thing I just want to point out here is we think a lot about the experience of care. What do patients and families want when they come or have to come to Children's Hospital? They say, keep me safe. They say, heal me, be kind to me, and ease my burden. And they say that in that order. This is after thousands of conversations with patients and families, moms and dads, when we have asked them over and over through the years, what do you want or need from Children's Hospital? Keep me safe, heal me, be kind to me, and ease my burden. And this is what I want to talk to you about today. So this is that same castle in Switzerland. This is from the other side, watching the sunset. This is the dark side of what happens, but the beauty that comes out of moments of failure. So the healthcare industry, this is a staggering statistic, but the healthcare industry kills Americans at about the pace of 20 commercial airliners crashing every week, and all passengers dying. That is the harm, the preventable harm that occurs in our healthcare industry today. So that is the context in which I talk about Children's Hospital. It is the third leading cause of death in our country, behind cancer and heart disease. Another perspective, so when you look at all industries, and you look at the number of encounters it would take for there to be a fatality, 0 to 10 million, as well as the number of lives that could be lost because of that error, anywhere from 1 to 100,000. This is where you want to be as an industry. This is where you do not want to be as an industry. So, it's much safer, bungee jumping, mountaineering. The safest industries, nuclear power is the safest, European railroads, and the commercial airline industry. Those in the middle, driving, chartered flights, chemical manufacturing, and healthcare, where you think healthcare is. One of the worst industries for safety as it relates to, again, not what we can't control, not that people will die of natural causes or of something that is a legitimate cause of death. These are preventable errors that occur in our healthcare system. So another way to think about that is that the probability that we will harm a patient in the U.S. healthcare system is equal to losing your luggage. About 1 out of every 616 patients will be harmed in some capacity. And levels of harm are different. Wrong medication given may or may not have caused a problem. But it could have been prevented, and because there were failures in a process that led to the wrong medication being administered, we need to pay attention to that, because in the cases where certain doses or certain types of medication that could be fatal, and often is fatal. So in our hospital, we had 2 stories. Sorry, every time I talk about it, I get emotional. So Grant was a precious little baby who was in our care, and he was having trouble eating, latching onto mom or taking any kind of nourishment. So he needed a feeding tube to help him get through a few weeks until his body could adjust to being able to eat on his own. The care team, who loved this child greatly, mistakenly placed the feeding tube in a part of his body that missed where it should have been and hit the lung. And so his feeding was going into his respiratory system, not his digestive system. And by the time we figured it out, we lost Grant. And so Grant's family has been a gift to us because through the years they tell this story and they work with our teams to help us learn from that in a constructive, productive way. Because the loss of their son, they wanted no other parent to have to experience that. And then there's Alyssa. And Alyssa was a beautiful young girl. She had leukemia at a very young age. So she was in our care for leukemia. And during the course of her care, she became septic and developed sepsis. And her mom was one of her best advocates, knew her child, and was calling to our care team, I don't think something's right with Alyssa. I need you to pay more attention to Alyssa. We did not hear Alyssa's mother. And by the time the right care providers were made aware of mom's concern and the care or the condition of Alyssa, it was too late. And we lost Alyssa to sepsis. And Alyssa's mom today travels across the country being the most vocal advocate for parental voice, moms, dads being a critical part of the care team, and how the voice of the parent can be one of the most significant drivers of what makes the difference in a life or death moment for their child. And so these 2 children occurred not too far apart from each other. And we had an opportunity as a senior team and as leaders of our organization to say, are we going to continue to rationalize that preventable harm happens in every hospital in the country? And that's just the way it is. Or are we going to try to do something different? And we had been on a safety journey for 4 years. We had been already adopting the right best practice, trying to do the right things. But these failures truly became catalytic moments where we had to stop and say, this needs to be different, and what are we going to do differently? And this is a story from a mom and dad. If I can get it to play in their words about the importance of parents. Oh, sorry. You won't get a voice or sound.
That's what we were working on with Games of Thrones.
Okay. Well, now you watch them. What they are saying, their son has had extremely complicated health conditions since his birth. He has not been able to ever have a cure or diagnosis actually identified for Jacob. His parents have chosen, they moved here from Germany, chose to receive care in Colorado because we had the assembly of the right patient experts and physician experts to care for what are the mysteries of Jacob's genetic disorders and his condition. What they are sharing is time and time again, there are events that occurred to Jacob that could have been prevented. Nothing has harmed Jacob, nothing has killed Jacob, but we still as an industry have moments where we do give the wrong medication, the wrong dose. We do have a miscommunication about a lab specimen that was Jacob's versus another child's. And they're talking about that role that parents have to play to be advocates in that care, and they're talking to the industry, physicians, doctors, administrators. How do you take this more seriously so that their parents don't fear leaving their child, their grandmother, their spouse at the bedside, because you always have to be watching what's happening in the healthcare industry. And so they tell that story in their own words to their experience with Jacob. And so this moment for us to truly look at what we needed to do differently is an important theme of what I think the essence of today is about. How do you think of failure and turn it into a success moment? How do you have the courage to recognize that you can't rationalize away, you cannot explain away that it happens to every hospital, that's the way our industry is, it's human, we're human, but that you really have to have the courage to do more. This has not been a recent phenomenon. The Institute of Medicine in 1999 came out with a landmark publication, and this is the first time in the consciousness of healthcare. I don't know how well socialized this really got into the sort of the general consciousness of just the country, but really within healthcare, we started to talk about this, that this was a really an unacceptable level of harm that we could prevent in our industry. A few years later, they came out again with version 2, and they said, you know what, this isn't just a gap we have to close, this is a chasm that we have to cross, and that this industry must respond differently. Now today, a decade later, we still as an industry are not driving that harm where we need to drive it. And that is still a call, a wake-up call, that most hospitals around the country have not answered the call to try to solve. You're all leaders. You probably know this model, but this is a model that I want to kind of walk what we did through. It is really Potter's change management model. You need to start by creating a climate for change. 3 steps in this first phase. What's the urgency? How do you build the team? And how do you get the right vision? And after you've created that climate for change, then you have to figure out how to engage and enable the entire organization to get engaged in making the change that you have identified. How do you communicate for buy-in, empower action, create short-term wins, build momentum through this phase? And then, how do you ultimately implement it and sustain it? One of the most difficult parts of change is the sustaining phase of making sure that what you have adopted sticks through the years, the decades. Our sense of urgency was very clear. Our sense of urgency was personal, and it had stories, it had emotions, and so for us, this was kind of our moment. Then what we had to do was build a coalition. And these conversations, you would think, in hindsight, they seem easy, but in the moment, they were challenging. So you have a senior team who cared greatly about this, but the senior team, we never really talked about this with our board of directors, right? Most board meetings I'd run, or my colleagues would run, we would talk about the financial performance of the hospital, the patient satisfaction surveys. Wow, 95% of all of our patients give us an excellent rating. We're doing great. Wow, we've got, we're growing. Our children who need us are seeking care from us. Wow, our employees love being employed. So we had all these great stories that we would talk to our board about. This wasn't really one of them. And so I'll never forget it. It's 2012. We were actually here in Colorado Springs at Cheyenne Mountain Resort, and we had pulled our board of directors down here for a 2-day retreat. We had just signed our lease agreement, and we're working with UC Health and Memorial Health System. And so we decided we wanted to hold our board retreat here in Colorado Springs. And we took an entire day of that 2-day retreat on this topic. And we shared with them for the first time the faces of the children we had harmed, the stories, and the numbers and the statistics of what that meant for us. That had been a conversation that had never occurred in over 100 years at our hospital. And it was such a bold moment because that board of directors could have taken a number of actions as a result. They could have fired the senior management team, they could have done mad things, but they didn't. They chose to take that moment of transparency, that moment of truth, that moment of trust, and to turn it into what is an essential part of this work. How do you create a just culture? How do you create a culture that recognizes the courage to understand what's happening and then begin to diligently and relentlessly solve it? And they have been our largest champion and advocate for this work. We tell them everything. We are completely transparent, and you'll see in some of our examples, we're transparent with families, with each other. We're sharing this work across the country because this is what we need to do, is build that urgency, not just within our 4 walls, but build that urgency within the hospitals in our communities, in our state, and across our country. And so that is how we began to take the coalition and build it, was truly from the top down. And then once the board was supportive of this work, not only did we get resources allocated to do this work in a fantastic way, but we also began to truly train the organization. Every single employee and physician, medical staff provider in our organization, so 10,000 people, went through the same training. Didn't matter what job you did at the hospital, you went through the same 2-day training. We did it in multidisciplinary teams, so that teams came together. Not all the housekeepers in one session and all the nurses on the 7th floor in one session, but the care team of the 7th floor came together. The care team around the perioperative surgery environment, they came together across disciplinary way, and we asked them to tell their own stories about moments that they knew of, situations they had been in, be vulnerable and talk about it. And I sat in many of those, and it was one of the most powerful things we did, was to have employees talking to each other in team environments about the impact of this work. We had never talked about it before. If the nurse knew she had given a wrong medication in the past, she didn't talk about it. Now we're talking about it. So those were the kinds of things that really began to build this coalition. It started with conversation, engagement, transparency. And the measurement was critical. We really didn't know what our baseline was. So we had thought we were tracking harm. And you could track harm if there was a significant event. You operated on the wrong limb. You've all heard those stories where they operate on the wrong limb, the wrong organ, the wrong vertebrae, So that we could know when something dramatic happened, but we didn't know when there was something that we call a near miss. We caught it before we actually had a harm moment. We started tracking all of it. How do you begin to know that there was almost a miss? Because those are almost as valuable as a learning tool as the actual mistake itself. Because you could see what was happening in the systems or the processes. Our caregivers do not come to work to intend harm. They come to work with the most noblest of intentions. So there are things in our processes and in our systems that are getting in their way or contributing to what happens. And so we started talking and tracking all of that. We actually saw a 10-fold increase in the number of events we reported into our system that track this information. And again, in the true spirit of a just culture, we celebrated that. We said, thank you. Thank you for letting us know that we almost had a harm event. Thank you, thank you. So rather than being concerned that our trend line was going like this, we realized that was a good thing because it wasn't being talked about before. So a low number wasn't a good thing. It was things had gone either underground or it wasn't appropriate to talk about in the culture. And now we have some of the highest event reporting, but that's a good thing because that's what we want. That's what we encourage. We also, in our coalition building, started looking to other children's hospitals. So the federal government, several years ago, worked with a number of children's hospitals in Ohio. Fierce competitors, right? I'm at one children's hospital in a 7-state region. They all are children's hospital in the same state. They compete viciously with each other. But they said one day, we're not going to compete with each other on safety for children. We're going to collaborate. And they came together and they created this coalition. And this is their work that they advanced over a 2-year period of time and where they continued to sustain. After they began to have success in and around here, they said, we need others to join. We were one of the first non-Ohio hospitals to join this coalition. And I'll show you our results in a minute. But we started doing this work together. Now there are over 100 children's hospitals across the country that are sharing all of our data, all of our events, all of our learnings, all of our best practice with each other. And we're adopting as fast as we can how we work on this together. And together across the country are making a significant impact in what we are able to do and say that we are reducing harm, preventable harm for children across our country. How do you get the right vision? I talked a little bit about the training, but we did have to go find the best practice. So we did our research, we found those Ohio hospitals, and we began both internally and externally to say, what are the best practices that we're going to adopt as an organization? How are we going to create the culture? How are we going to have every employee in our organization, all 10,000 family members, commit to behaviors that keep patients, families, and very importantly, each other safe? Because the other thing that we needed to do was create a culture that the team felt embraced and they felt safe. Safe to be honest, safe to make mistakes, but to learn from those mistakes. And so we adopted safety practices, we adopted a questioning attitude. Healthcare is very hierarchical. The attending surgeon to the fellow in training to be a surgeon, to the resident who's just doing a surgery rotation, to the OR tech, to the OR nurse. There is a hierarchy and a rhythm to how hospitals work. And we have to break through that hierarchy. And it has to be okay for the scrub tech to say to the attending world-class surgeon, I think you just left a sponge inside the body cavity, and not be afraid that that surgeon is going to treat that scrub tech differently in that moment, but to stop and to pause and to say thank you for helping me keep our patients safe. That is a huge cultural shift in the healthcare system that has prided itself on hierarchy. So we had to create that and how true standards and how we communicate clearly and respectfully. Leadership played a big role. So leaders don't touch the patients, but we lead the areas of patient care. So what were the expectations we had for leaders? So what does a just culture mean? There's a whole science to just culture, and we had to put our leaders through that. We had to round constantly rounding. It's not just rounding to say, hey, how are you today? How are things going? But to truly understand the work that is being done and to help the frontline staff members break barriers, to solve problems instantaneously. And then feedback, constant feedback loops, SBAR, situation, behavior, assessment, and recommendation. How did we get better about giving feedback and communicating in that questioning culture? And then a tool that's very helpful in this work is a cause analysis. Really understanding what happened and why it happened. Not jumping to conclusions too quickly, making sure the emotion is appropriately in check so that you truly can do a diagnostic of what happened. Because the most important thing we can do here is to understand what happened, why it happened, and that gives us the best ability then to understand how we can solve for it and fix it. These are the preventable harm. These are the big 10. So the things that are creating close to 100,000 deaths a year in our country, readmission rates that could be prevented, they don't need to occur, central line associated bloodstream infections, urinary tract infections, ventilator-assisted pneumonia, surgical site infections, adverse drug events, pressure ulcers, serious falls, obstetrical adverse events, and venous thromboembolism. So those 10 drive the majority of the harm that could be prevented in healthcare systems across the country. Then the theory in healthcare around keeping it safe. How do you have a governance that really embraces this work and creates a lot of the dynamics that I talked about? How do you bring leadership methods into the organization at the next level? How do you adopt best practice error prevention strategies, do effective root cause analysis, create high reliability, and I'll talk more about high reliability, and engage patients and families. And I would say on our journey in this model, we absolutely have the governance support, we absolutely have leadership methods, we are continuing to develop and find and discover best practice. That is an ongoing journey, but there is evidence of science. We are deploying best practice tools here. We can usually not work them fast enough because it is just ongoing learning opportunities, but we deploy them. This is the hardest thing we're doing, and really are not on this journey at all yet. Healthcare is not a highly reliable unit. That is where, we were up here on that one grid, nuclear power was down here. They're highly reliable. How do we go from here to here is that journey. And then we absolutely have engaged patients and families. So we have tried to sort of make sure and check ourselves on each of these. But again, that's that honest look in the mirror as a leader. It's easy to get distracted. Healthcare reform. Oh, we've got to employ all the doctors, or now the insurance industry is going to change. There's so many distractions in healthcare. So we always, as a team, have to discipline ourselves. How do we come back to this? This is our true norm. This is what is the most important priority for us, while everything else in the noise in the healthcare industry spins around us. But that's hard. That is hard to do, and we have to consciously be intentional about coming back and staying focused on our true norm. Communicating for buy-in is another step in the Chicago change model. It's everywhere in our hospital. When you log on to your computer every day, the first thing that greets you is our safety page. What's the safety story of the day? We have walls across the organization where we are talking about. This is in one of the most trafficked hallways in the hospital. How many patients we harmed in the month of September last year? We put that up. We talk about what it was, what happened, and we're learning about it constantly. Units, this is just a shot from one of our units. Number of days since their last central line bloodstream infection, since their last patient ID error, or their last pressure ulcer. So they're monitoring it and tracking it at a unit level. And then empowerment for action. We have been doing tons of things. Every day, from our patient safety officer quotes a story. We share a story every day with our organization about a safety moment. It could be a good catch. This nurse on this unit happened to notice that the wrong order for medication was entered into the electronic health record, but the nurse caught it. We celebrated. Great job. Or something didn't go so well. We have actually found in our hospital, because of catching it, that some equipment manufacturing had major defects that nobody had noticed for over 6 months. But because we were doing such effective cause analysis, we were able to identify it, call the manufacturer, immediately did a recall and pulled it out of circulation. But that was just something that had been going on for months without being caught. But those were because stories were being told, and a person on one unit read it, thought they had the same thing on their unit, they would share, and we saw patterns and trends faster than other organizations could see it. We play games, we have fun all the time to keep this fresh and alive. Visibility I talked about. Every day we start our morning with the daily safety brief call. Every leader across the organization gets on and reports out whether they have a safety concern in their area or their unit. We listen to that every day, and we do both immediate actions and then things that are harder. We track longer-term actions, but we're monitoring it. And we've built very sophisticated dashboarding that can be drilled down to the individual nurse or the individual doctor, in addition to how they look as teams. And then short-term wins. This is our journey. So when, after that board retreat in 2012, and we started our journey, where we knew of, these were the serious events. So usually we know of the serious events, 4 per month. There were 4 children having a serious event in our hospital every month. So our little wins, we celebrated. And in those micro moments, you have to celebrate, because you still are heartbroken by this number. How do you keep morale up? How do you keep people engaged and not lose that ability to just be so demoralized that we can't do this? You have to celebrate. We celebrate. When you look at it now, over the course of Horizon, you can see that every big journey starts with that first step. And that's what it takes. And as leaders, that's again the courage for you to just find what is your sense of urgency, what is that failure that you can use as a gift to turn in to the success, start the journey with the steps, and you will be able to accomplish that if you embrace that failure can be a gift and lead to success. We stay very focused on the quadruple aim. This is being talked about a lot more in healthcare. What I'm talking about a lot is the outcomes. What is the actual outcome of the health experience you have? But it's so much more than that. It's staying in balance with the patient-family experience, how the team members feel. Increasingly, healthcare is an industry, people are saying they burn out. They just burn out. Why? This is a hard industry to be in. How do we not make that happen? How do we continue to encourage and make it a resilient culture to be a professional in? And then now, more than ever, the value proposition. How expensive is healthcare? Can we afford the healthcare system we have? How do we keep all that in value? And making sure that that balance is there for our industry. Don't let up. We're in the final 2 stages of Cotter's model of change. This is our Chief Quality Officer, Dan Hyman. Every year we have a bike race in the mountain called the Courage Classic, where we raise about $2.5 million to support the care of children at our hospital. And there he is, never letting up on his journey. And I love this quote: "The single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes." And I thought that was really powerful, again, for the essence of what you were trying to talk about today, is that for our industry is the single greatest impediment. And so how do we embrace it and make a success moment out of it? And then making it stick. I mentioned high reliability. The nuclear power industry has adopted this high reliability model for decades now. They are preoccupied with failure. They're modeling cause events that have never occurred. They're scenario planning for things that haven't even occurred, in addition to always doing cause events on things that have. They don't oversimplify. They have an absolute aversion to oversimplification. And the higher you go in a leadership position, sometimes the easier it is to oversimplify, because you're looking at such a macro view of things and have to see such complex things and get them translated into something understandable. So there's a tendency sometimes to oversimplify. They don't let that happen in their industry. They're highly sensitive to operations. So they're acutely aware that the slightest thing out of place, the slightest button that might be blinking, what does that mean? And they're going to focus on it. We don't really do that in our healthcare culture. They're committed to resilience, and they have a deference to expertise. say, not safe, can't advance this policy, this protocol, this change, this action. And that is something that, again, our industry has to adopt. This is where we now are, is figuring out, even at Children's Hospital Colorado, after heartbreaking failures and our courage to adopt a change model, this is hard. This is hard. And this is now where we just stand on the first step of this journey in our organization. So with that, I think that's the end of my comments, my story, and I am here for questions or however you wanted to facilitate these next few minutes. Thank you for your time and attention and willingness to hear the story and be on this journey with us. Thank you.
A lot of what you brought up was quantitative. You can measure it. How do you know, and what changes have you made to know you're listening to parents, hearing what they have to say about their kids?
Great question. The question was, if you didn't hear it, a lot of the things that I talked about should be quantitative and measurable. But how do we know the more qualitative? How do we know we're actually listening to families? A couple of things that we've done. One, upon admission to the hospital, and we do this for outpatient visits as well. So upon registration, when you're coming into the organization, the first thing parents get is something that's called Speak Up. It's one page. The registration clerk or the nurse, who's ever handling the conversation, literally says, we value your voice. You are the most important member of the care team. We need you to speak up. And so families are encouraged from the very first conversation to speak up and advocate for their child. And we also, in pre-admission packets, so if a child's having surgery and you send home the pre-information, we are communicating that to parents proactively. Second thing we do is rounds, care rounds. So we try to, now this doesn't always work, but we try to have the doctor, the nurse, the pharmacist, the care team with the parents participate in care rounds. So the doctor's reporting out what they think, the nurse is reporting out what they think, pharmacist, whoever's part of the team, and mom and dad always, if they're able to be there, and this is where this is hard, because not always are parents there, or at different times, but if they're there, they have a voice in that conversation. What are you concerned about today, Dad, as it relates to your son? And then Dad can say, I'm not concerned about anything, or he looks a little funny, or he's less active than normal, and I'm worried about that. And so we make that a part of the conversation. We also have family members sitting on over 50 hospital committees. That was one of the things that the American Hospital Association said they had never seen before. We literally invite them into the hospital committees, and they're active parts of our designing policies, processes, systems, the work that we do. We listen to the parents as we think about how we redesign our work and pick priorities and make changes.
Before you went on this campaign, what was the culture like for self-reporting mistakes or punishing people for mistakes as it is where it is now?
I've been at Children's for about almost 12 years. I don't believe there was ever punishment for mistakes, but there wasn't encouragement per se to acknowledge that. So it was almost like it was more passive, if that makes sense. So I don't think people were punished. I don't think it was punitive. But I do think it wasn't celebrated, encouraged to report. And that's why we saw that tenfold increase in reporting. We'd always had a system, but what we've noticed as we've gone back and looked at the types of events that were reported in the beginning of this journey versus the types that were reported now, we didn't pick up the near misses. We would pick up the things that actually hit the child. The wrong medication, the wrong surgery, the wrong surgery was an obvious one, but things that always weren't so obvious might have been the wrong medication, the wrong dose. I sent the lab sample, I put the wrong label on, so it should have been Johnny's label on the test tube, not James's label. So we would get those things, but now we're getting a lot of the near miss. Because people are saying, wow, I almost did blank, and if I did, somebody else might actually do blank. And so that is what we see a lot more now because it's so encouraged.
council.
It's a great question.
How do you react to that level of transparency?
It's a great question. These were some of the harder conversations. Was just being able to say, yeah, there is the chance that by the level of transparency that we have with families, with the community, with any key stakeholder, that we could have adverse events. But yet we were willing to take that risk. And so she actually learned how to become an advocate in that for us, and not a barrier for us. But we had to talk through that. And we had to realize that that was a risk we were taking, but that was a risk we were prepared to take. And there is actual evidence now that really says the more transparent an organization is, or a physician or a practitioner is, about a level of harm that has been impacted, actually now lower incident rate of lawsuit or legal action. Now that's not foolproof, because people are human and every part of the country is a little different in their litigation cultures. But for us, that was a very crucial conversation we had to have as a team, and we had to have with our board. Are we prepared for this? To take this kind of transparent action with the understanding that that could open a whole bunch of negative press, negative publicity, lawsuits, etc.
So a number of us in here have worked in our careers with unapproachable attendings in one form or another. And so I was intrigued by your comments about open communication and basically exposing issues. How did you find and how do you continue to foster that communication with those who may think they don't need to listen?
Yeah, so there are a couple of things, because it is still an issue. It is, and again, I think sometimes it's just the nature of people and personalities who chose certain professions. Sometimes I think it's the hierarchical, I was abused when I was a resident and fellow, and therefore I'm going to abuse. I think there's still some of that we're trying to get over. I'm so thrilled about these younger generations that are coming out that don't have that either history or that value set. So it still happens, but some of the most effective things that happened was our head of surgery, and he'd tell you this story if he were standing here himself. Head of surgery actually was about to make an error in the operating room, and it was a surgical tech who stopped him and said, "Sorry, Dr. Conwell-Home, but I think that you need to, stop and pause and verify that that is the right arm that you're about to do surgery on." And Tim's first reaction is to get angry. He'd been up, he'd been in surgeries already for 12 hours. He's on his 13th hour of surgery. He's grumpy, he's tired. And he didn't treat that surgical tech very well. That surgical tech had the courage to not back down at that moment, but to reassert in a productive, professional way, say, "No, I'm sorry, I really think you need to stop and check this out." At that point, the rest of the care team had now joined in the team conversation with the surgeon. So Tim talks about that and how that felt to him and how he had the process. His innate reaction was to be pissed, was to think that person, how does that kid know what they're doing? I'm a surgeon, I've been a surgeon for 30 years, But he talks about it in a way that really elevated that surgical tech as a member of the team that was the guardian of safety for that child in that moment. And you need role modeling. He needed to be vulnerable. He needed to tell all of his surgeons that he had made that mistake, that he had treated that person poorly when he should have celebrated that person immediately. And he talked about that. So we need people to role model. We also need processes to call behavior. I have had numerous conversations, as well as my chief medical officer, with providers. If they are not living to the values and the standards of this work, we are happy to excuse them from our medical staff. And we will, and we have actually taken that course. And I think that, again, you have to embrace that, and you have to get your actions in those moments. We give people the opportunity to try to change behavior, be successful, because we always believe in people's success, but if they cannot be on board with this work, they cannot be part of our organization. Yes?
Two-part question. Can you talk about the steps that you guys took to reduce your high turnover, and then how that in turn, with retaining those employees, help to reduce the adverse events.
Yeah, healthcare, so we're fairly fortunate at Children's. It has always been and is a pretty special place to work. People usually choose pediatric healthcare for that mission. And so we don't have as high of turnover as other hospitals that have quite high turnover, but we still have it. So about 7-8% of our workforce will turn over involuntarily on an annual basis, and that's about half the rate of what other non-children's or other hospitals are. But for us, what concerns me is this fatigue, this absolute. It's change fatigue, it's emotional fatigue, and it is, I think, just increasingly, nurses, long-standing seasoned nurses are the ones most impacted, not wanting to work as long or as hard or as much anymore. Newer nurses coming in, watching this, saying, this younger generation, they want balance. They don't want to work, We used to think the 12-hour shift, that was great for one era. They're sitting here saying, no, I kind of want to work here maybe for 4 hours, and then I want to be off for 2 days with my kids. So we're in this really interesting time. But what I worry about is the emotional toll that healthcare, these are, particularly in a children's hospital, these are some of the sickest children in the country. And how day in, day out, how do we keep them whole and keep them resilient and feeling strong and taking care of our caregivers? And then I worry about this, the pressures, the compliance. Healthcare is one of the most regulated industries on the planet. And so there's always a new rule, always a new regulation, this and that. You got to chart here. They're spending more time in electronic health record than actually touching patients. It's all of that sort of compounds on itself. So I don't have the magic answer. I think this is really a challenge as an industry, is to figure out how to keep the work sacred, how to keep it effective and efficient so that caregivers can do what they train to do, which is to serve patients and patient care, and make sure that we're managing that bureaucracy, the regulation, the rules, but we're doing it in a way that doesn't overly burden them and take away the joy of what they signed up to do. So it's an aspirational answer to your question, but I think it's a challenge for the industry across the board. Question is, what types of roles do our volunteers take on? So we have about 2,500 volunteers, and they do everything from literally run the gift shop to manage the sibling. We have a daycare center on site so that parents who have children who might be with us for months, and the families essentially move in. We have volunteers who run the daycare center. We have volunteers who teach. We have a lot of kids who, because they can't be in school, they're with us for months, that we have teachers that come in and teach these kids and help them homeschool along so they don't miss out. We have volunteers who do arts and crafts projects, who spend time just by the patient's side. So sometimes in the NICU, when we have babies where parents need to get a break, they need to go to work, lots of volunteers just holding the babies and being there because physical contact is so important. So it ranges for probably hundreds of different things, really suited to the volunteer. We have a lot of volunteers who also serve on our various board committees, where various committees bring their subject matter expertise to help us solve problems that we might not have subject matter expertise in. It's a wide range. We're definitely ahead. The children's hospitals across the country are about a step ahead of the non-children's hospitals, and that's why we're spending a lot of time talking to other hospitals and other hospital systems. Interestingly, Medicare has had some quality standards that you may or may not call safety standards, but quality standards, pseudo-safety standards, that they have measured adult hospitals against in order to receive certain levels of payment from Medicare, which is a huge payment source for most adult hospital systems. So that's kind of how they've prioritized their work, is that list of stuff, because that affected their reimbursement. We're now starting to see adult hospitals do that, plus look at some of this other work in a more systematic way. And so they are beginning to adopt it. But it's kind of fun to know that children's hospitals across the country are kind of leading that charge and sharing everything. I think since January, we've had at least 5 different adult systems come tour and just see what we do and how we do it and talk to our teams.
Even though you're talking about children's hospital as being part of that whole, the inshoots or that whole system up there, are all the hospitals taking on, do you know, are all the hospitals taking on this effort like children's is for reducing harm?
Yeah, so on the Anschutz Medical Campus, the CU, Academic Health Sciences Center, is there. So the schools of medicine, nursing, pharmacy, dentistry, public health are on that campus. And then 2 hospitals, Children's and the University of Colorado Hospital, and hopefully soon to be the VA. So, and we all do gather as kind of campus neighbors and talk. And so University Hospital, I know, is putting a lot of emphasis into this work. They also have hospitals kind of across their broader system. They're doing it, Centura is doing it. Centura has been very active in quality safety work, as well as the Sisters of Charity of Leavenworth. And so that's wonderful to see that those hospitals take this work very seriously, all systems.
What system or program are you using to identify the root cause of the issues?
Yeah, so we use a couple. Some of the basic is the fishbone diagram. So the way that this will happen is we'll identify an event that gets reported into our computer system, documented. Immediately, our quality safety person or team will go and do an interview with the person who reported. So there's a live interview that occurs and a sort of a capturing of the narrative of the story. Then from there, a team assembles. We pull the right group of key stakeholders together, depending on the nature of the event, and a team looks at it, and then the team decides, okay, here's now the other people we need to interview in the process, and now we run in the true fishbone and really begin through the interview process, data process, looking at processes and systems, sometimes observation. If we know that a particular system might have been a fail point, we literally will observe that process. We'll go back into our database to see if it had happened before, what we had learned. But usually that fishbone is a very basic tool, but it's actually a really good tool. And then we prioritize the Pareto kind of chart. Okay, you got 9 causes, but which were the primary causes and what are secondary causes? And then we take the primary causes and we say, okay, we must have actions on these. This is our top priority. And we assign accountable people. We track it. We report it. I get notified if action plans remain open past the allotted time to solve a problem. I have to get involved then if, after I make the call and that leader hasn't done it, we continue to escalate if needed, but I've never had to do that. Usually just a phone call does it. The action gets closed, and then we track it, and we monitor sustained impact on the primary. And then the secondary, we also work, but sometimes we give ourselves more time to pay attention to secondary actions, because this stuff turns a lot. There's so much activity that now we're having to really prioritize the impactful stuff, and then okay, this stuff is sort of secondary.
So do you have thresholds at what you'll use that process for?
Yes, yeah, we do. And my team, if they were here, they'd whip that down. If you're ever interested, be happy to share our actual policy and procedure around that. What are the criteria that we look at to triage, essentially, which process and which tool set and what criteria. We do have all that.